Here, myself, Dr. Anamika Chaudhary, first year ophthalmology resident from Rio RIMS Ranchi. My topic is clinical and demographic study of ocular trauma due to firecracker injury in a tertiary care center. India's vibrant festivals and celebrations often involve firecrackers, but tragically, firecracker accidents might result in serious ocular injuries and irreversible harm to vision. From minor epithelial defects to severe globe rupture, firecracker injuries in India span a wide spectrum. This study on firecracker injuries is crucial in shedding light on the impact of these celebratory explosives. The aim of my study is to evaluate the spectrum of ocular injuries, clinical and demographic profile, and management patterns following injuries in patients attending tertiary care center of Jharkhand. Methods and materials. It's a hospital-based retrospective study of patients attending the emergency department of Rio RIMS Ranchi. The sample size is of 25 patients and the duration is from May 2023 to April 2024. The patients who sustained ocular injuries by firecrackers were included in my study, and the exclusion criteria was the patient with extraocular injuries that were very severe and life-threatening, requiring multi-speciality managements, and patients with already existing ocular pathologies. Vision assessment was done using Snell's chart. Detailed ophthalmic examination and fundus examination was done in all cases possible. USG B scan and X-ray was done. Patients with severe injuries were advised admissions and managed either conservatively or surgically. Injured eyes were irrigated with copious amount of normal saline, and particulate matter and soot particles were removed. Patients were prescribed antibiotics, steroid eye drops, tapered after a week, lubricating solution ointment, and cycloplegic eye drops. Surgical intervention was done in cases required. So the results. We saw that the age range of these patients was from 3 to 70 years. And surprisingly, and often which is found in all the studies, that 15 patients were less than 20 years of age. 18 patients were male, whereas 7 patients were female. So we found that in our study, bomb crackle was the most notorious firecracker found to be associated with severe injuries in 39% of cases, followed by flower pot in 29.5%, with bottle rocket and then sparkles. None of the firecracker victims reported using any protective eyewear at the time of injury. So this is the spectrum of ocular injuries due to firecracker which we saw. It ranges from periocular burn in almost 100% of cases, followed by corneal aberrations, corneal foreign bodies, corneal perforation, conjunctival and lid laceration, hyphema, iridodialysis, globe rupture, vitreal hemorrhage, and retinal detachment in severe cases also. So we have classified the injuries in open globe and closed globe, and then accordingly into zone 1, zone 2, and zone 3. So these are two pictures: slit lamp examination, periocular burns showing hyphema, a picture showing retinal detachment and some other injuries. So the surgical interventions were performed. That it included lid repair, corneoscleral tear repair, corneal tear repair, scleral conjunctival repair, AC wash, and evisceration. Later, some patients underwent lid reconstructions for correction of psychiatrical entropion. So this is the visual outcome following injury. We have compared the initial vision and the final vision after treatment. So now I proceed to the discussion part. Injuries to the eye and adnexa constituted about 20% of firecracker injuries. The Cohn et al. Found that 60% of firecracker injuries were sustained by children. Most bottle rockets were of injurious nature, and the devastating visual outcomes were seen in 10% of cases. So, to mitigate ocular injuries, it is essential to develop strategies that focus on standardizing the quality of firecrackers available in the market. Promoting awareness through school-based social and seasonal programs can significantly reduce such injuries. Educating children, parents, and teachers about the risk can also play a significant role. Additionally, leveraging media platforms such as television, mobile devices, social media, or newspapers can contribute to public education on this matter. So I conclude that firecracker injuries lead to physical and mental trauma to the patients. This could be very devastating and can lead to permanent vision loss. So enforcement of legislation and regulation of firecrackers and promoting their safe use via school and media will have a positive impact in the society. These are my references. Thank you so much, everyone.
Thank you, Anamika. So, did you do CT scan in any of those globe rupture patients?
Yes, sir, we suggested, but not in all the cases. Patients could not afford also, and they were in.
So what would be the best investigation for a case where there is a penetrating injury or a globe rupture? Open globe.
Open globe rupture, so we can go through an X-ray orbit and see the foreign bodies there or not. And
Yeah, but I think the best localizing
CT scan,
will
of
be,
course.
because instead of going for ultrasound and
Yes, sir.
X-ray, you can probably save some time
Yes,
going
sir.
for
CT
CT scan.
Yes, sir.
How many of these eyes had a PL negative vision?
So one
On
of my
presentation.
patients, it was PL negative, and we have to eviscerate that eye.
Okay. Did you try primary repair?
Yes, sir, we tried, but it was not possible. It was a complete globe rupture with a very penetrating injury, and nothing was left, so we had to eviscerate. No option was left. He had an injury with his bomb, and it directly hit his eyes. There was some stone or something inside that.
Thank you.
Thank you so much.
So, who else is there? Shruti is there. Vanaja. Yeah, Shruti. You are? Yeah, okay. So the next paper is Outcomes of Pediatric Open Globe Injury at a Tertiary Care Hospital by Vanaja Iyer.
Good afternoon, everyone. I am going to be presenting paper on outcomes of pediatric open globe injury at a tertiary eye care hospital. In the pediatric age group, ocular trauma is a leading cause of non-congenital visual impairment. The predictors would be age,
5 minutes. So just
visual acuity,
stick to
wound
that.
length, location, iris prolapse, lens injury, endophthalmitis, vitreous hemorrhage, and retinal detachment. In spite of advancements in medicine, these result in substantial visual impairment and hence a lifelong sequelae. Hence, in these cases, prevention is much more important than treatment. The aim of my study was to assess visual outcomes in pediatric open globe injury patients. Objectives were to assess improvement in the best corrected visual acuity as well as analyze the causes of these cases. The study was conducted at Mahatma Eye Bank and Eye Hospital. It was a 1-year study with a sample size of 18, and the study type was prospective type. Pediatric patients coming to OPD diagnosed with open globe injury were included in my study. Patients who were not willing to participate and with age greater than 18 years were excluded. After written consent, the demographic profile was recorded, detailed clinical history was taken, mode, cause, type, and zone of injury were also included. Detailed ophthalmological evaluation including best corrected visual acuity, anterior segment, posterior segment examination was done. Appropriate management was done. Patients were followed up and outcomes were assessed at 6 months. The sample size was 18 with a significant male predominance accounting to about 16 cases out of 18. The mean age group was 8.8 plus minus 3.64 years. The most common cause that we found out in our study was from wood bamboo stick and pen pencil injury. The most common type of injury was penetrating type, followed by rupture, followed by intraocular foreign body, which was seen in about 2 cases. The most common zone that was involved in our study was zone 1, followed by zone 2, followed by zone 1 and 2. In one case, we found out that it involved zone 3. The baseline mean visual acuity in all these cases was 2.15 plus minus 1.47 logmar, which improved to 0.23 plus minus 0.18 after treatment. Statistically significant improvement occurred in visual acuity on follow-ups post-surgical management with a p-value of around 0.01. About 60% of the cases required a primary wound closure. In 4 cases, we did wound closure along with cataract removal plus IOL implantation. Out of the 2 intraocular foreign body cases, 1 required foreign body removal with anterior vitrectomy, while in the other one, it was accompanied with cataract removal plus IOL implantation. The most common type of injury in our case was penetrating type. This was consistent with studies conducted by Aksu, Silan et al. And Lee X et al. Zone 1 injury accounted for majority of the cases, which was similar to the studies conducted by Chen H et al. And Lee X et al. Significant improvement in best corrected visual acuity occurred post-operatively on subsequent follow-ups. All eyes were preserved and showed improvement in visual outcome. Greater improvement in visual acuity occurred in patients with a better baseline visual acuity as well as an earlier presentation. No patient was lost to follow-up at the end of the study. Limitations of my study are a smaller sample size and a shorter follow-up. To conclude, I would like to say that the study showed that pediatric open globe injury was seen majorly in age group between 7 to 11 years, with a significant male predominance. It was seen that these injuries result in significant visual loss, but timely and appropriate management resulted in significant improvement in visual acuity in almost all of these cases. Injury by pen, pencil, wood, bamboo sticks accounted for majority of the cases. However, studies with larger sample size and a longer follow-up can definitely help us reach much clearer conclusions. Challenges that we face in these cases are repeated evaluation under anesthesia, multiple surgeries may be needed, care and multiple follow-ups, post-operative amblyopia and glaucoma management. My takeaway message would be, timely and appropriate management definitely results in significant improvement in visual outcome in all these cases. Without a doubt, we should all focus more on the children and definitely create a safer atmosphere for them. These are my references. Thank you.
Thank you. So, what was your pediatric population till what age you took as?
Sir, we included up to 18 years.
Up to 18 years. Okay. And how many of them underwent multiple surgeries?
Sir, 2 of them.
underwent
The
multiple.
intraocular foreign body ones, both of them.
They underwent multiple. And how long is the follow-up?
Sir, I assessed at 6 months, but then
You have longer follow-ups
Yeah,
as
we
well.
do have. But then for standardization, we assessed at 6 months.
Okay, I think thanks.
Thank you, sir.
Thank you. Rajna is there? Anybody else who's there? Rishi Sharma, Veronica Agarwal. Are you presenting? Yeah, sure. What is your good name? Okay. Please come. You are presenting directly from the laptop, or you have a... Yeah, you can bring... Hall coordinators, please. Hall coordinators, please. Can we send out a message to the presenters? Is it possible? Yeah, please. Any of you is a presenter?
May I have the permission?
Yeah, please. Major Shruti.
Yes.
So the
Good
the
afternoon.
topic is ocular trauma in counterinsurgency and proxy war environment.
Yes, sir.
Epidemiological study,
Yes.
2008 to 23.
Good afternoon.
Please start.
Everyone. Yes, thank you, sir. Good afternoon, everyone. Sorry for the last minute adjustment. I just got the permission to present this.
That's fine.
The topic is epidemiological study of combat ocular trauma in counterinsurgency in proxy war environment in scenario of last 16 years study. So this was a retrospective study. Data from 2008 to 2023 was collected and was evaluated, and all the hospital admissions. Total of 948 patients were evaluated at my center, that is 92 base hospital, which is situated in Srinagar. They were evaluated initially based on the severity, whether only anti-segment injury or post-segment injury as well, and they were given primary care and then referred to further higher center based on the severity. So this was the incidence of combat ocular injuries in the previous study which was conducted from 1992 to 2004. So this was the initial part which helped me to do the study, to continue the study from 2008. That's the data I could gather. So coming to the incidence of combat-related ocular injuries, it was only 3% in Indo-Pak War. It increased to 4.8, 10.5 and 15.8 in Iraq-Afghanistan conflict. See, what becomes most important when it comes to combat injuries, the projectiles which come, any blast, okay, affecting the periphery, any part of the bodies, it will be a smaller injury. But since eye is a small structure, any smallest of the foreign body falling into the eye or going back, it causes a severe injury, including in case of a grenade blast or any UBGL injuries. So the ocular trauma and counterinsurgency, the factor which can be considered in transporting, like how early the patient reaches. Not all the conflicts are happening in Srinagar, that I am taking care right away, that they'll reach me in another 10-15 minutes. They're sitting somewhere far off, taking about, even if they're taking by air also, they'll reach about minimum 6 hours to reach me. So the factors which were considered was casualty transportation. The evacuation time also mattered. Even though we could give the early treatment, the patient could recover, and the medical equipment limitations and initial assessment limitation, and you are evacuating a casualty in an environment of war. So there is an active war still going on, and you'll have to evacuate the patient, prioritize, because life, limb and the site. This is the order of priority of transferring the patient. These were the year-wise case distribution from 2008 to 2023, and to be more precise here is the open globe injuries incidence is decreased in the last 3 to 4 years. The ranges of closed globe injuries and more of training related injuries is increased than compared to the actual combat scenarios. The closed globe injury which we saw at my hospital, blunt trauma was 407 cases accounting to 47%. Coming to splinters, 135 cases, and IED leading to closed globe injury were 10.46 and firing related injury were 26%. And open globe injuries, firing accounted for about 20%, and blunt trauma leading to open globe injury was 21%, stone pelting and firing the blast and splinters thereafter. So combat related injury are still in the rise. Let it be, even though the shift is from closed globe injury has changed to open globe injury, so open to closed globe injuries, but the injuries are still there. It still leads the serving soldier being morbidity. He'll not be fit to serve, and preventable. And all these injuries are preventable if only we can use better glasses, protective glasses. We can prevent the injuries, and military eye combat protection devices can be given to the soldiers to prevent injuries. Thank you, and so sorry for the short notice.
No, that's fine. Thank you. We just want to know a little more about it.
Yes, sir. Yes, please.
Yeah. So this is a study conducted by
yes,
you.
Yes, sir. This is a study.
So,
yes, sir.
Have you been serving?
I've been there for the last 2.5 years at Srinagar.
Okay.
And
so this is a retrospective study from that particular base hospital.
Yes, sir. Yes, sir. It is one of the active Northern Command theatre.
And these are all
so mostly
soldiers,
yes,
or
sir. Sir,
yes.
mostly soldiers, sir, because there includes Central Armed Forces as well as BSF, military as well as paramilitary.
Military and
yes,
paramilitary.
Military as well as paramilitary.
Okay, and like, what do you feel was the time between injury and presentation to you?
Sir, if the initial thing is where IMOs are situated, the medical officer who assess the patient are also in a place where there is no network.
Yeah,
they'll have to walk minimum 10-15 minutes to reach to a point where they can get network to send me the photos. just to tell ki whether even though they can tell it's an open globe injury, and there are many issues.
Yeah,
that
of course, that's what we want to know.
So for
Because
to
these
transport
are,
the casualty, and
I'm sure you are working in a very difficult situation, and that's why we want to know more about it.
yes,
So you have included stone pelting as well.
yes, sir. Stone pelting.
Okay.
Even though the incidence is decreased
Yeah.
drastically from
Yeah.
what it was before,
Yeah.
but they're still there. This all these data.
So what
Sir,
kind of?
I'll tell you the most recent case which I had was a case of LASIK flap dislocation. I've made it as a poster as well. A serving soldier, 6 years old, surgery. He was doing something and he ended up with LASIK complete dislocation. The MO took 6 hours to transport the patient, and as soon as the patient came, we took him to OT and repositioned. Everything went in.
That's
went
good.
fine.
That's
So-
good. But do you take people in armed forces with LASIK?
No, sir. It is initially it is not. It got missed somehow, but
Yeah, like
Yes.
otherwise I think
It
it is
is
a
high, sir. They are
contraindication, or
unfit-
there is some relaxation for
Yes,
to a
for all.
particular power or something?
yes, yes, sir.
Okay. And any particular, like, I think you might be knowing more of these guidelines, but
Yes.
any
I-
particular power and any particular procedure is
Sir, for officer entry for NDA, different for if you are
Okay.
joining NDA, IMA, and technical as an AMC officer, they're different. for
there are different
yes, yes, sir.
criteria
Yes,
for
sir.
all.
Yes,
Okay.
sir.
So on an average, it is about -4 or
Yes, sir.
less.
-4 or less. Both spherical as well as cylindrical, including cylindrical power, it should be -4.
Okay. And you include flap, like you allow flap
No,
or
sir.
only
we don't.
PRK nowadays?
No, sir. None of the refractive for serving soldier. None of the refractive error is allowed. None of
Okay.
the refractive surgery is allowed. But for officers, LASIK should have been done 1 year prior. Not
Any kind of LASIK?
yes, any kind of refractive
LASIK?
surgery should have been done 1 year prior.
Okay. Prior to the entry?
Prior to the medical he's getting.
Medical
Yes,
he's getting.
not it should not be a recent surgery. And age of the patient should be more than 18 years.
Of course, of course. That's so for NDA, like at the entry, only the medical will be done.
Yes, yes, sir. For everybody, all of
For
us,
everybody,
yes,
like
all of
because
us undergo
those
proper-
are the people. I think they join after +2 or something.
Yes, +2. Yes, sir.
Yeah.
All of them will undergo proper medical evaluation and then.
So for your kind of patients which you were getting,
Yes, sir.
what how much first aid or what kind of a treatment you could give, and how many people needed referral?
Sir, initial treatment we gave it to everybody. Primary repair, wound repair was done for all the patients. No
Okay.
patient was referred without primary repair, especially in case of closed globe injury, open globe injury. And closed globe injuries, if we are suspecting retinal detachment, retinal dialysis, we do refer them. We have referral system. We have a higher center, AHRR. That's the apex center for us. Army Hospital, RNR.
R&R.
Yes, sir, Delhi. So
Okay.
we refer to them.
So that is the nearest
Yes.
referral
Yes,
hospital
yes,
for
sir.
you.
Yes, sir, referral hospital.
Okay, good. And this is Northern Command Hospital?
No, sir. Yes, it's in Northern Command.
Northern
Yes.
Command, basically. So it's fully equipped with to handle interior segment,
Yes, sir. Can handle entrism. Yes, sir.
not the posterior segment.
No, not the posterior segment.
Okay.
So,
So we wish that you get trained in posterior segment
Yes.
and serve us.
yes, sir.
Thank you.
Sir, thank you. Thank you so much. Thank you.
I think we'll have to wait. Anybody else? I'm sorry to say that few. No, that's absolutely fine. But I think you need to get permission from your whatever CEO and all that. Yeah, that's fine. That's fine. Absolutely fine. Yeah. We might get some photographs done for presenters as well, please. Presenters, please stay till the end of the session. Take a seat. Yeah. after post-graduation? That's great. So nowadays it is permanent commission. That is 18, minimum 18 years? 20 years. Okay, good. So you are, oh, good. Both graduation as well as post-graduation. So you are with the army? You are with army. Great. I have a very close, now retired. He retired as brigadier. No, he's Gurunath. V. Gurunath. I don't know if you know him. He is now serving in Andhra as principal of some medical college. We did VR training together in RP Center. That that was long back. It's almost more than 25 years. So he retired as brigadier, I think. When he was doing that time, he was a major, I think. He was a major. Yeah. So you are interested in VR? Okay. So which all places you can go to? RPC? Okay. I think Netralaya also you can go. No, because Madhu Baduria used to be in Netralaya. She was on a long-term fellowship. You know her? She also retired as brigadier probably, because now she is director of Sitapur. She is president of WOS, Madhu Baduria. So I think it's a great career. So you know self-defense also? Huh? Part of the training is firearms training as well? Okay. So you have to go to the field also? No, not really.